This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I interview Mike Stewart to discuss the impact of language on patient outcomes. We talk about how the words we use influence treatment and impact outcomes, how to develop communication and teaching skills, what words we should avoid using, and suggestions for alternatives, how to address the impact of language and patient beliefs after they read an MRI report, and much more. Mike is a physiotherapist with almost 30 years of experience helping people overcome pain. Mike has a master's degree in education and is a dedicated practice-based educator, passionate about providing education to a wide variety of health professionals. If you find this conversation interesting, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians if you might benefit from this conversation. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Mike, welcome to PT Pro Talk. How are you today?
I'm great, thanks Mariana. Thank you very much for inviting me to talk to you. It's an absolute honor.
Awesome. So let's get started talking a little bit about yourself and your careers for the ones that don't know you.
Yeah, so I'm one of these strange people. Maybe some of your listeners are the same. Maybe you're the same as well, Mariana. I knew that I wanted to be a physiotherapist from an early age. So when I reached about 14 years of age at school, I just understood that that's what I wanted to do. I wanted to work in healthcare, particularly physical therapy. And then I got lucky enough to train to be a physiotherapist. And by the time I reached 21, I was a qualified physiotherapist working in Cambridge in the UK. And by 23, 24, maybe 2 or 3 years of working with patients, I suddenly felt very disillusioned that the profession was not doing what I hoped it would do. My training advised me that I was going to fix and cure people, and I realized quite quickly that I wasn't fixing and curing people. And people kept coming back saying, what you did last week worked really nicely. Please do it again. And so I started to wonder if I wasn't very good as a physio. So I've always lived with this imposter syndrome, this feeling that if I can't fix people, maybe it's me. Maybe I'm the problem. Maybe my colleagues will fix them much better. So I now have almost 30 years of a clinical experience of being a physio. I'm still absolutely fascinated by the stories that people tell me, the narratives that people explore with me about their problems with their life and their pain and how they cope. So yeah, I think it's a wonderful job. It's a complex job. It can be challenging emotionally, physically, but I think it's an absolutely wonderful job. And I would advise anybody who's listening to stick with the job or to go into physical therapy if it's not something you've already thought about.
I share the same feeling. I always knew that I wanted to be a PT since I was like in high school. I was a gymnast, so I would go to PT every day. I was like, that's what I want to do. I want to help people.
Yeah, it's strange, isn't it? I'm a twin. I have a twin brother. We are now nearly 50 years of age. My twin brother still doesn't really know what he wants to do. He moves his jobs, but I was always laser focused. I knew exactly what it was I wanted to do. And I think it maybe comes into the conversation we're going to have today. I think that some of the problems looking back was that I was very naive. I thought that physiotherapy was about fixing things, about the person on the sports field who runs on with the magic sponge and the water to cure the injury. So I was thinking about physio years ago as just a physical thing, a thing that we do to somebody's body to fix their problem. And well, we can explore that how it's not just this; it's so much more than this.
Yeah, I guess we are lucky. We knew since the beginning what we wanted to do.
Yeah, it helps.
And so we're talking about fixing. So we know it's a lot more than that. I know you talk a lot about education. So to jump in that topic, so in your opinion, how can words influence our treatment and impact our outcomes?
Yeah, well, my master's degree is in education, and I think the one thing that I learned in that master's degree was that when we work with patients to try to educate them and advise them, which is what physiotherapy is, we do it often without realizing we do it completely wrong. Because the word education comes from a Latin word educare, and educare means to draw out things from inside people, not to pour things into people. So I think, I mean, I don't know about you, but I know for me and for lots of other people I meet, the way that we try to educate our patients and advise them is by we do all the talking. The patient disengages. They're a passive recipient of our knowledge, of our information. So it's almost like a copy and paste method. I talk and my knowledge goes into the patient's brain and they just listen and they remember all the things I tell them. This is rubbish. This is not good education. E.M. Forster once said that spoon feeding in the long run teaches you nothing but the shape of the spoon. So people don't learn by just talking at them. So your question is about the impact that words have. I think we have to begin with an understanding that the answers to people's problems lie in them, not in us. So our words can have often negative impacts on people, or they can have very positive impacts, as we'll see. So you can either help people or you can harm people. As a clinician, we sit in a pivotal role where we can either do help or harm. But actually, maybe the best thing to do is to not talk. Maybe it's to listen, because the answers to people's problems lie in them. And if we can draw out, educare, to draw out, if we can draw out people's stories and experiences, then that's where the answers are to help people. It's not from the words that we use. It's from listening to the words that they use. That's more important. So I think that's a really crucial shift.
Yes, and I think we do a lot of lecturing, just vomiting our knowledge, thinking that we are doing good. So that's very interesting. I like when you said that you draw out of the patients their stories and we just listen, because sometimes I guess we feel like we want to be in control and show that we know things, and we start lecturing and thinking that they are absorbing and understanding, when a lot of times probably not the case.
No, it's all about control. And I'm a big fan of 30 years of experience as a clinician has taught me that we need to lose control. I think we can learn a lot from driving instructors, because I often ask my patients 3 questions. I'll say, do you drive a car? I'll say, yeah, I've driven a car for 25 years. I'll say, okay, great. When you learned to drive, how many lessons did you have? Well, so 10. I had 10 lessons. How many times have you needed the driving instructor since you passed your driving test? And the patients will always go, I haven't. I don't need the driving instructor. I know how to drive the car. They taught me what to do, and now I have the skills. And that begins with understanding that the patient has to have the steering wheel. You've got to, it's their story, it's their narrative. It's not for us to say, this is what I want to do today. So I think the first really important lesson when it comes to communication and education is, if you want to help someone, we have to shut up. We've got to get much better at understanding that, we have the universe is trying to tell us something. We have 2 ears and 1 mouth. The universe is trying to tell you something about this, because the answers really do lie with them. And I think that's a crucial idea, that if you're going to empower somebody, if you're going to give them some understanding, empowerment begins with us losing power. We have to lose control. We have to give them the steering wheel and allow them to tell us what's happening, and then we guide them.
Yes, that's what I was going to say. It's more like you're guiding them on the process. You are not dictating what they are doing.
Yeah.
You are engaging them and engaging them on the treatment, so they feel they are participating, they are giving their inputs, and we are guiding them through the process.
Yeah, very much so. The educator Dallos, he once said that, like guides, we walk sometimes ahead of our students. If you change the word student to patient, it's no different. Sometimes we walk ahead of them. So we're informing, we're directing, we're saying, I need to show you this, or I need to talk to you about this. At other times, we're walking together besides each other. And at other times, they're guiding where we go. They're in front of us. So we're listening, we're following their lead. And he suggests that the art of effective communication and the art of effective teaching is knowing where that dynamic is. Knowing whether you're talking, whether you're listening, whether you're following, whether you're directing, so some people, I've met students before who have this very natural ability to do this. It is an art. It is a science. Communication skills are skills that we can learn, just like learning manual therapy skills, for example. You can develop these skills. They're not just something that you have innately. Some people do. But for most of us, we have to think about how can we learn these skills? How can we develop them and understand the impact that language has?
Yeah, so that is my next question. So how we develop these communication and teaching skills. So how do we guide our patients?
Yeah, I think, as we've said, I think the first thing it begins with is an understanding that we don't guide. We don't do the guiding all the time. It's not for us to say, let me tell you what to do. Because the problem is people do disengage. If we talk and they listen, they switch off. The other problem, as we've already highlighted, is that if we talk and they listen, we will say things that we don't even know what we've said. We may say chronic degenerative disc syndrome or Schmoll's nodes, or, you may use some jargon, because this is the other problem with guiding people and with language, is that we have knowledge. As a clinician, we understand biomechanics, we understand anatomy, pathology, but in that knowledge, there is a curse. The curse of knowledge is that we get to know something so well that we completely forget that our patients don't know anything about it. Let me give you an example. I once saw a lady, and she came into me and she said she had a problem with her knee. And I said, look, this is how the knee looks. Here's a model of the knee. So I showed her this anatomical model of the knee. And I said, this is the patella. And when I said patella, she said, I have a Spanish rice dish like a paella. What is this? And she'd never heard the term patella. So I had to then, because it surprised me, and I had to then say, a kneecap, the kneecap, the cap of the knee. And she said, oh yeah, I know kneecap. Now, of course, we forget all of the time. So this is a huge problem with language, is that we know things so well that we forget other people don't know them. We will say degenerative disc changes. We know in our head what that means, but we don't know what the patient interprets this word as. So we always have to consider that gap in understanding, that gap in perception. These jargon words are so normal for us. There is another problem as well when we're guiding, that sometimes we have to be very careful to not be paternalistic, to not be like the parent and be the didactic sort of clinician who's saying, let me tell you everything. This is what you need to do. You follow my rules. And I think to a degree, there's a problem in healthcare because we learn all these skills to try to be the fixer, to try to rescue people and save people and feel good about ourselves and, try to reaffirm the skills that we have. But in the middle of doing all of that, we lose patients. Either we bore them with our jargon or they feel stupid. There's lots of research to show that patients often feel stupid, because we'll use words like spondylolisthesis, and the patient will go, oh, am I supposed to know what that word is? So it's almost like where some clinicians show off, they sort of pleasure
Mm-hmm.
themselves with their own knowledge, and the patient is left feeling stupid. As I say, there is research out there to suggest that patients do feel like we are the scientists, we understand all of these terms, but they don't. And it's a power dynamic. We keep the power and we don't let them have it. And as we said before, the first rule of empowerment is that you have to lose power in order for your patient's power to rise. So guiding comes from losing power.
Yeah. And I think like our education is very focused still on this biomedical model that we use all those terms, we learn those terms. So how do you envision us evolving as a profession? Like how can we change that? Maybe not necessarily the way we learn, because we learn the language, but we don't learn how to communicate in simple and practical terms with the patient. So like, what do you think that it needs to change in our education to help us overcome this issue?
Great question. I think there's a few things. I think the first thing that has to change is the shift in the amount of learning that we focus on biomechanics, anatomy, pathology. There was a study by Briggs, Carr, and Whitaker here in the United Kingdom, and they found that 99% of all healthcare students' course, their curriculum, is biomechanics, anatomy, pathology, which means that less than 1% of their training is spent developing education skills, communication skills. How do we empower people? How do we know how much to support people and to challenge them? So there's got to be a shift in that dynamic, because Judy Foreman is an American health journalist. She spent 4 years interviewing 200 patients, researchers, clinicians. She came to the stark conclusion. She said there's an appalling mismatch between what people in pain need and what clinicians are trained to do. So there's this huge gap, and I think we need to recognize that. We need to move towards understanding that actually we are not mechanics and our patients are not motor cars. We're human beings dealing with other human beings in vulnerable situations. And when you're vulnerable and when you're in pain, pain is linked to your perception of threat, how safe you feel in the world, how threatened you feel. So if we don't see that big picture, and if we just stay looking at what's happening with the mechanics, the tendons and the muscles and the joints, then we will always just remain in that sort of very small block. Let me try something with you, Mariana. I do this with patients and I do this with students as well. Yeah, maybe you could do it with your patients too. Do you ever meet patients and maybe colleagues who they just think about the biomechanics? They're just thinking about my pain is coming from the L45 disc on the left-hand side?
Yes.
Yeah, and I meet colleagues like this too. They're just thinking about this. Anything to do with psychology, anything to do with sociology, or it's for somebody else. My job is I'm a mechanic. I'm like working with a motor car that's broken. I've just got to think about the mechanics. Well, let's try something. I do this with patients, and it's a bit weird, but it sort of tries to teach you a point. I'm going to give you 3 letters. Can you tell me how you're going to pronounce these 3 letters as a word? So CHO. How would you pronounce CH?
Show.
Cho? Yeah, that works. Okay. Let's look at another word now. PHO. How would you pronounce this word?
Fo.
Yeah. Okay. Final word, I promise. USE.
Use.
Use. Okay. So now, Mariana, I would ask you, and I'd ask my patients and my colleagues to do something. In your head, put those 9 letters together. So the first word was cho, then it was fo, then it was use. What does that word sound like as one word?
Cho use.
Chofo use. Does chofo use mean anything in Portuguese? Does it mean anything in English? Or does it... Chofo use means nothing in any language. I've traveled teaching around the world a lot. Chofo use is meaningless. It doesn't have any meaning. So now, if you try writing down those 9 letters in front of you, And then tell me what word you have on the piece of paper, because it certainly isn't chofo use.
Chop house.
Chop house. Like a nice steak restaurant where you go and buy a nice T-bone steak. So what does this teach us? I mean, what does this mean about information and guiding people and communication? What it really means is that if you're just thinking about CHO, you're just thinking about bio, you're just thinking about the disc inside the back, then you're losing all of this big picture. CHO faux use is meaningless. CHO is meaningless. So unless you pull back and you see the big picture, unless you can contextualize things and put things into some bigger place, which is understanding that a human being is not just a series of muscles and tendons and joints, but is a living mechanical organism that has a belief system and a cultural system. And, so we have to understand. I think your question was, where are we going in the future as a profession? I hope that we're moving towards a much bigger picture of how human behavior links to rehabilitation, what our job is in terms of trying to help people in a bigger context, not just thinking about CHO, the joints, the muscles, tendons.
Yeah, because it would be great if the education would include those, like for students that are graduating, because we're now being, listening a lot about it, learning about doing continuing education courses. But like us as professionals have to go after that information is not something that is included in our learning system. So I think that would be a big, big thing that I don't know how long it's going to take for the curriculum to catch up with all these new concepts. Not so new, but they are not part of our education formally.
No, I think another really important thing, I mean, we developed a group for patients. And one of the first things that we did with our pain education group is to involve patients who've been around the healthcare system many, many times, and said to them, what could we do to improve? What are the things that, from your experiences that you've had in healthcare, what do we need to get better at? And I think we need to do the same thing with undergraduate healthcare education, particularly in physical therapy, is to say, well, what's been good? We have to help patients to be part of that process and understand, how we could develop. And I think a lot of that involves listening more, talking less, not coming in with our preconceived ideas of, these are the exercises that I'm going to give you, do them 3 times, 10 times a day. Just going through the motions of what we do, like there's a formula or there's a recipe. There really isn't. I mean, Bullington, the researcher, said once that to encounter another human is to encounter another world. So each time we meet another human being, the world changes. It shifts completely. So there cannot be a formula. There can't be a recipe. So we have to, this is another thing we have to get good at, is the ability to be creative, innovative, to think on our feet, to try new ideas with different people, not to be scared of new concepts, new ideas, not to just stay with the recipe that keeps us in our comfort zone, but to be confident to step outside that comfort zone and to enable our patients to do likewise.
Yes, and I know that we have a lot of terms that we use in our vocabulary as physical therapists that sometimes for us, like you said, patella, it doesn't mean anything. It's like straightforward, the name of the bone. So and sometimes can cause a different impact on the patients, can be catastrophic. So I really like that table that you share with me, the sticks and stones that show few terms and the words that we can use instead of those terms. So would you like to just highlight some of them to give some ideas for the listeners, that words that I can use that would not be as perceived as maybe harmful for the patients?
Yeah, sure. I think the first thing to understand is that this is an old problem, the idea that words can cause harm. Rudyard Kipling, 100 years ago, Rudyard Kipling gave a talk to the Royal College of Surgeons in London, near where I live. And he said in that talk that words are the most powerful drug used by mankind, And he went on to say that words can change the way somebody thinks or feels, like drugs. Words are really powerful. They change the way people think about the world. In one way, words are like toothpaste. So imagine, Mariana, if I got you to squeeze some toothpaste out of the tube and then asked you to try to put all of that toothpaste back inside the tube, it would be very, very difficult. So words are like toothpaste. And I think as a clinician, some of the words that I'm going to talk to you about from the table in the study we spoke about, some of these, I think as a clinician, you're either somebody, if you're like me, who spent your career trying your best to put those words back inside the toothpaste tube. I've spent my career trying to undo the harm that's been done in 1 second by a clinician without them even realizing they've done it. They've said Schmoll's nodes when they're describing an MRI scan, and then the patient's on the phone on Wikipedia, and they're finding all these horrible images and things. So you cannot undo this because the toothpaste is out of the tube. It's already there, and we have to accept that the damage has already been done. So you're either one of those people who's trying to undo that harm, or you're somebody who's causing that harm. You're someone who's doing it, but you're not realizing you're doing it. Eccleston and Crombez once said that pain is an ideal habitat for worry to flourish. And I think often as clinicians, we unwittingly fertilize the ground. The words that we use act like fertilizer, and they're toxic, they're radioactive, and they build this worrying picture of pain and disease. And so let's give us some examples. So words like chronic degenerative changes, we've suggested that, patients, a lot of people will hear these words. Oh, you have some chronic degenerative changes. And a clinician will say that without even thinking, because of that curse of knowledge. We know what it means, but we forget what impact that has for the patient. So we've suggested that maybe using the term, normal age-related changes, so it's normal. And there are a couple of ways that you can do this with patients. If we look at chronic degenerative changes, for example, I often jokingly say to my patients, I have a chronic degenerative disease. And they'll say, oh, do you? Oh, I'm sorry to hear that, Mike. And I'll say, yeah, look, see this here? I used to have long hair. I used to have hair like yours, Mariana. So I used to have long hair like this. But look, I have chronic degenerative hair disease. And of course, this is a joke because we do not call it chronic degenerative hair disease. It's going bald. And you either do one of two things. You either normalize it and it's just part of getting older and it's fine. And then you accept it and you move on and you continue with your life, or you don't. You fight it and you battle it and you try to, find a fix. You buy a wig, or you try to implant some hair and spend lots of dollars and money trying to solve this degenerative hair. Do you see the problem? This is normal. This is normal. Another way to do this, when people try to help patients and they say, oh, this is normal for your age, you're 55, in 75% of people at your age, we would see these changes in your discs in your back. That can be helpful to look at the statistics and to show them the data. But there's a problem with this because it's sort of information. And we know that information just goes here and then it goes out here. They don't remember those statistics. So instead, try to do something a bit more engaging, a bit more fun. So I would, for example, say to my patient, if they said, well, I've been told I have some chronic degenerative changes in my discs, I'll say, right, okay, I want you to imagine that you have a superpower. You're like an X-Man, and your superpower, your superhero power is MRI vision. So you can see the world with MRI eyes. Go to the end of the marathon, the Paris Marathon, Rome Marathon, London Marathon, whichever. Go to the end of a marathon, go and look at the finishing line and watch as people pass the finishing line. With your MRI vision, you will see everybody's spine. And some of those marathon runners are 84, 89, 93. We have very elderly people who run marathons. How do you think their discs look with your MRI vision at 84 years of age? And the patient, of course, will say, oh, they probably don't look very good. Well, they don't have discs. Those people's discs, they disappeared when they were in their 60s. So 20 years ago, their discs disappeared. But look at them. Look, they've got a big smile on their face. They've just completed a marathon. They're really happy. Now do the opposite. Go to the local kids' hospital. Go and see that 7-year-old girl who's in a wheelchair and she's really struggling to stand up, lots of disabling back pain, and use the MRI vision superpower that you have with that girl. How do her discs look? And if patients understand, because they'll often say, oh, they'll probably be fine. She's only 7 years of age. So you're trying to set up some degree of cognitive dissonance, some degree of distance between what they think should be logical, that the pain is coming from my degenerative discs that my clinician told me about, and actually the liberating idea that it doesn't matter really what your discs are doing. What matters is how well you're doing, how well you're living, and how safe you feel or how threatened you feel.
Yeah, it's like their perspective, how they decide to absorb that information and move forward.
Yeah, this is it. I mean, I always remember having a patient come to see me and she said that, in the past, her clinician had said to her that she'd looked at an MRI scan of her back and she said, oh, this is a problem. If this was your knee, they would replace this knee. They would give you a new knee. But it's your back and they can't replace it. And of course, this left an eternally negative, pessimistic. She was only going to end up going downhill physically. She's going to be in a wheelchair. There's no hope for this lady. It's only a life of harm and hurt. But when she realized through education that actually it didn't really matter too much, it wasn't about that. She was just thinking of Cho, not Chop House. Then she realized that actually there was other things. And once she started to live life, she said, this is liberating. I feel completely liberated because it doesn't matter really what my discs are doing. What matters is how well am I living the life that I want to live.
Yeah. Yeah. It's like those terms, like I have a bulge disc, I have a disc herniation, I'm bone on bone. Like when they come with those MRI reports with all these conceptions of like, okay, now my life is ruined.
Yeah, or some of the words, we used other ideas in that table that we were talking about, which was, don't worry. I mean, how many clinicians have said to patients, I've been guilty of it, where you say to the patient, don't worry. And, what's the first thing you do when you tell someone not to worry? Don't worry.
Worry.
You worry. It's negative suggestion. Don't eat the big juicy marshmallow from those old psychology studies in the 60s. All kids can think about is eating the big marshmallow. So don't worry tells people to worry. So instead of that, don't worry could be termed as, well, things are going to be okay, or giving a more hopeful, optimistic slant on certain things. So, for example, the word chronic. We know Barker and colleagues did a study where they looked at the words like chronic. Chronic to us means time-based. So as a clinician, we think of chronic as time, more than 3 months. But to patients, that same word chronic means, one participant in Barker's study said 2 steps from a wheelchair. So chronic means bad. Chronic to us is time. Chronic to a patient is bad. So maybe a better word is persistent. It'll persist. Your pain will carry on. It will persist for a while, but you can overcome it in time. Another word, for example, is instability. So for us, we know what instability means. It's that curse of knowledge again. But for our patients, one patient in a study said instability means liable to pop out. I'm really weak. I've had patients before who've said that my physio told me that I have an instability in my spine and I need to do some Pilates to improve my core stability. And of course, what they want to do now is lie in bed or put a belt on, put a brace on. They want to protect their spine because they now feel like they're really unstable, like a Jenga, that's going to collapse and fall over. So the word instability not particularly good. Maybe instead we could say, there's some weakness, but we can make it stronger again, rather than saying, oh, you're unstable. It's counterintuitive, it's counterproductive to rehabilitation.
Yeah. And like you're going to have to live with this. I like that one, that a lot of people just say like, hey, you're going to have to, learn how to deal with it, live with it. And then I like that you put like as an alternative, you may need to make some adjustments, but you're going to be okay, trying to be reinforcing, being positive.
Yeah. It's all about how well people can adapt. And I think in my career, the people that I've seen who do best are those who, maybe you'll work together for a few months. And at the end of the process, you'll say, oh, how are you doing? And they'll say, oh, I'm loads better now. I'm back in work. I'm playing with my kids. I'm back doing sports again. And you'll go, great. That's really good. How's your pain? And often they'll say, oh, I don't know. I've not really thought about it. Because what you've helped them to do is you've helped them shift their focus away from pain and much more towards function, towards life, pleasure, things that they enjoy doing, and I think this is a crucial thing, that when people live with pain, they reduce their pleasurable activities. They try to sacrifice pleasure in order to stop their nervous system from erupting with pain all the time. So we have to help people to get back to living a pleasurable life. And in doing so, things get back to normal, and the perception of pain reduces gradually over time. That's the hope.
Mm-hmm. And then like with your patients, do you avoid asking the question that to rate their pain level and things like that?
Yeah, I try to. I try to avoid talking about pain as much as I possibly can, because we know there are huge problems. I mean, we're all trained in asking people the VAS score, 0 to 10, how's your pain? But there's an innate problem with this, because if you want somebody to recover from pain and to overcome pain, maybe we need to take the focus away from pain. Maybe we need to start to think about, as we've said, function, getting back to things that are enjoyable or meaningful to you in your life, looking after your kids or whatever. But if I just consistently keep asking people what their pain level's like, it's a bit, let's try something now. I do this with patients. Could I get you to put your thumb in front of you, Mariana? So could you do this? Yeah. I get my patients to try this. So could I get you for like the next minute just to stare at your thumb? So I get my patients to stare at their thumb for a minute or two, and they can do it when they're at home. They can do it when they're on the toilet somewhere quiet. And you'll start to notice, maybe in a podcast, it's quite tricky to do, but the more you get your patient to start focusing on their thumb and just thinking about their thumb, the more they start to feel their thumb. They say, oh, my thumb's got pins and needles, or I can feel my heartbeat inside my thumb. Or, if you really concentrate on what's happening inside your thumb, you will switch on your thumb. So this is a real problem, because if we're constantly saying to patients, how's your thumb? How's your thumb? What's your thumb like? What's your thumb like? Well, we're doing it all the time. What's your pain like? How's your pain? What's your pain doing? It's cognitive bias focus, and we need to shift that cognitive bias.
It's tricky because most of the sessions, we always ask that to our patients.
It is. It's really, really hard. And it's in a way, it's counterproductive. I tend to shift when I'm working with patients. I'll tend to shift the focus as quickly as I can, help them make sense of pain, and then shift that focus as quickly as you can towards function. So if you're looking for something else instead of VAS of pain, then maybe how about I try like a 0 to 5 confidence. How confident are you to do this physical activity? You've said to me that the thing that you really want to return to is playing with your son. How confident are you on a scale of 0 to 5 to pick your son up from the floor? So you can start with that. I can think about confidence to doing meaningful, pleasurable, valued activities, rather than a simple numerical scale of pain. There's another thing as well. I mean, one patient in one study said, my pain is evil. Where would you like me to place that on your numerical scale of 0 to 10? So you cannot place a human experience of pain on a
Mm-hmm.
number, on a numerical chart. One patient
Mm-hmm.
said to me, "What is this? Some sort of sore neck bingo? It's a game. You want me to place a number on this?" Think about how you would express any other human experience. So, for example, wine, if you like wine, if I asked you to describe wine and what the wine tastes of, you wouldn't be able to say to me, if you really liked wine, you couldn't just say, well, my wine tastes of grapes and I would rate it 3 out of 10. That doesn't work. Or love, do you love your husband? Yes, I do. I would rate my love 7 out of 10. Yeah, it's very limiting. It doesn't allow the
Yeah.
human being to express their experience. So I think we need to understand the problems with this question and maybe move beyond it.
Mm-hmm. Yeah. And just curious, like on your practice, do you use other scales to like try to shift away from pain, like you said, function? Um,
Yeah, we do functional testing. So we video record pre and post, so before and after functional tests, so patients can see, because I think it's really crucial for people to see that there's a change. If you want
yeah.
to explore the language of optimism and hope, we have to show people that they can change. This brings me back to, we said about the impact that words can have. So, for example, if you said to me, Mariana, well, I want to be able to run the marathon in 6 months' time, do you think I'll be able to do that? For you as a physio, you have a choice of words that you could use. So you could say maybe, or perhaps, or possibly, or probably. And what I do when I'm teaching groups of people, if we have a room of 30 clinicians, I'll ask those 30 clinicians what percentage chance they would put on that word right now. So if it was, 15:47, 3:47 in the afternoon, what percentage chance would you put on the word possibly? And everybody in the room will say something different. Well, 30%, 80%. What about the word maybe or perhaps or possibly? And that number changes completely. And of course, if I ask you on a Monday morning at 9 a.m. the same question, that percentage chance that you relate to possibly or perhaps or maybe, it will change completely. It'll change if you've had a coffee, if you had sex yesterday, if the sun's shining, if it's raining. There are so many different things that can impact on people's mood, people's optimism and hope, and their pessimism and their despair. So I think we have to be aware of the words that we use. Like if we say perhaps, perhaps with some confidence, perhaps, or perhaps, so non-verbal body language counts a huge amount. I teach a lot about that.
Yeah. And I was going to ask you, like, so on your classes, so how do you teach? And you are talking mainly about communication and like how you express with your patient, how you educate them. So what is your course about?
Yeah, the course is often about developing teaching skills. So, a lot of the work that I've been doing over the years in looking at education in healthcare, how do we become better teachers? So, for example, when I did my master's degree in education, I didn't really understand. I thought I was doing good education with my patients, but I realized that I was just doing what I thought was good education. So I do something. Everybody, when I go to teach, I'll always say, look, um, do you provide education and advice to patients on a daily basis? And every physio puts their hand up. Yeah. I give advice. I do. Well, how many of you were trained as teachers? How many of you were trained to teach? And very, very few physios are. So we are teachers without teaching skills. So my course is about teaching you all of those teaching skills that you never learned. How do you challenge people? How do you support people? What does good coaching look like? Then a lot of the work that I do as well is looking at developing communication skills, and that involves a whole load of creative ideas to start to get people, give people the opportunity to tell us their stories better. So looking at lots of different creative tools and ideas that you can use and skills that you can develop. So lots of communication, lots of education. Yeah.
Things that we should learn in college.
Should learn. And often, we call these skills soft skills. We often hear in healthcare, they'll say, oh, well, communication and education are soft skills. They're anything but soft. They're very hard. And they make a huge difference to your patient outcomes and to how well we can make good relationships and build therapeutic alliances and rapport with our patients.
Yeah. And I was curious also to ask you, so those patients that we see after they receive their MRI results and they come with all those like, but you don't understand, I have a bulging disc. So like in your experience, to change this perception and this impact that was already done in the patient, now they have their beliefs. So like how hard or how easy it is to change their perspective with the education? Because as you said, when it's out, the toothpaste is hard to put it back. So how do you, in your experience, how do you deal with that?
Great question. It can be very challenging because I think if you think that your job is to eradicate that threat, that understanding, is to try to put the toothpaste back inside the tube. So the patient leaves your clinic saying, oh, this is fantastic news. I feel liberated. There's no harm to my discs. You're going to be sorely mistaken because you can't. That damage has been done by that clinician who said those words, who did that education with the patient. So your job now is, and again, something else I teach, is to try to assess how flexible is this person? How psychologically flexible are they? Dyer once said, if you change the way you look at things, the things you look at change. So in other words, can I get this person, and I'm always thinking about every patient I meet or every student I'm working with, how psychologically flexible is this person? How easy is it going to be for me to help them, to guide them away from that way of thinking whilst they still have that concern? Can they overcome that concern and start living their life again? So, for example, we have patients who come to work with some of our students at the university, and the students will say, oh, you must be better now. You're now an expert patient. You mustn't have any pain now in your back. And the patients will say, oh, no, I still have pain and I still worry. There are still moments where I'll go to bend forwards and I'll feel pain in my back. And I really worry that I've caused some damage inside my back, that my disc has exploded, So you can't make that fear disappear. As Mark Twain once said, courage is resistance to fear, mastery of fear, not absence of fear. So can you get that patient who's read that MRI report and is really frightened, can you get them to a point where they can master that fear, master that worry and overcome it, but still live with it? They'll still have it. It'll still be there. Mm-hmm. And that's I think where the skill is how do we shift somebody's understanding while still accepting that worry may well linger, it may well persist and continue, just like the pain may well persist and continue. Another way that you can do this, another way that we can help people to explore this is I show people, I have a photograph that I show them, and it's a photograph of a telephone. It's just a telephone, and it's like an old telephone with a wire coming out. And I'll say to the patient, if you look at this picture of this telephone, could you tell me with 100% confidence that you would be able to call your mother or call your wife or your husband using this telephone? I'm only going to give you this 2D photograph of a telephone with the wire coming out. Could you tell me with 100% certainty that you could make a phone call using this phone? And the vast majority of patients will say, no, I can't be certain, because all it's doing is showing me a 2D image of a telephone and of the wire, of the electronics. And of course, that's the problem with an MRI scan, is an MRI scan is just a 2D picture showing you the structure, the telephone, the body, the muscles and the joints, and the spinal cord, the electronics, the wire. But you can't tell whether that phone's working or not, whether it's okay, it doesn't tell you anything else. It just shows you a picture. So
Yeah.
it's trying to find, I think, meaningful ways and creative ways, not really boring ways at talking at the patient, but using an experience to get them to change their understanding and to master that understanding, to overcome that fear.
Yeah, I love that example of the phone. It's
Yeah,
perfect.
yeah.
So, Mike, do you have any recommendations of where people can go to look for more information, any resources that they can look into to help them in this area?
Yeah, oh, there's plenty. I mean, I have a whole resources page on my website. So the website is nopain, knowpain.co.uk. So you can find a resources page there, and there's a whole load of things from patient blogs, articles, podcasts, for example, TED Talks. So I keep adding to that resource list. But I would say, I mean, if we're thinking about communication, I always like to ask people a question. I always say, well, how do you prefer to learn? Do you prefer to watch things or read things or listen to things? So I think if you like reading things, when it comes to communication, I would recommend David Biro's book, The Language of Pain. David Biro, a very interesting book because David Biro is a doctor who writes about his own personal experience of living with pain. And he writes about how we think about pain, how we've spoken about pain over the years throughout literature, throughout novels. So it's a really interesting read to get a good understanding of how we think about pain. So David Biro, The Language of Pain, is a good book. I think if you like watching things, there are lots of ideas, lots of things to look at, but I would highly recommend looking at YouTube. Ernesto Sirolli, Sirolli. And the title of his TED Talk, it's a TED Talk that he gives, it's on YouTube, is Want to Help Someone? Shut Up and Listen. And it's a really good, I'd highly recommend it for any clinician because I think the stories that he tells in his talk have a lot of meaning and a lot of reflective sort of ideas for us to think about in our practice with patients. And listening, I think, again, there are a whole load of podcasts out there and audiobooks. I think in terms of audiobooks, any of Robert Sapolsky's work, Professor Robert Sapolsky has some amazing audiobooks on being human and human behavior. I think they're fantastic listening sort of ways to try to learn. So I would always think, and the same with our patients, when you're trying to guide patients towards resources, I always think about how do you like to learn best? And then if they say, well, I like to listen to something whilst I'm walking the dog, or I like to watch something whilst I'm commuting into work on the train, great. So I can guide them according to their preference.
Very good. And Mike, any advice to clinicians that are starting their careers?
Yeah. Oh, God, there's so much. What would I have done differently? I think that, the biggest piece of advice that I would give is that I would encourage people to spend as much time as possible with other colleagues who are not physical therapists. Whenever you get the opportunity, if you ever have any time where you can do personal development, I would make contact with your local psychologists, your local surgeons, your local nurses, your local OTs, your chiropractors, osteopaths. Go and spend time developing not just a network of people who you can get to know so you can help, refer patients onwards if necessary in future. But I think it's really important because you then spend time watching and listening to how other colleagues, how other clinicians work and how they talk to their patients. And I wrote an article a while ago called Stuck in the Middle. And it's all about how patients get stuck in the middle between what the physio says, what the doctor says, what the chiropractor says, what the OT says. And I think there's a huge need for more interprofessional learning and understanding what each other's doing. Because, of course, we're all saying things to these patients and they're in the middle listening to conflicting ideas. So I think the more we can spend time working together, I think that will limit the impact that has.
Yes, have a universal language. That would be the dream. I'm
I
not
think
sure
so.
if one day it will happen.
No, let's hope so. Let's hope so. But we will always, Louis Gifford always used to say, who you see is what you get. So if you go and see an osteopath, you'll be given some osteopathic advice. You go and see a physio, you'll get some physio advice. But of course, if you see 10 different physios, they'll all say 10 different things. Because yes, we're all physios, but we all think differently. We all have different ways of understanding the world. So who you see is what you get. It's really crucial.
Yeah, yeah. And anything else, Mike, to add? I know we talked a lot. Anything else that you wanted to add to our conversation?
Yeah, I mean, I would say keep hopeful. I really am a firm believer in when you're communicating with patients, we are in an ideal position where we're working with people who are distressed and vulnerable. And I think you have to bear in mind that your experience is very different to theirs. And I think we have to do everything we can to try to make people feel more optimistic, more hopeful for the future. And I think always keep your focus on positivity. Try to sort of look at how we can shift that language towards more hopeful, optimistic, positive words. Keep your focus there.
Okay, great. And Mike, if people want to contact you, find you, is there a way they can contact you?
My email is mike@knopain. So again, that's KNOW PAIN. mike@knopain.co.uk is my email. I'm always happy to answer questions. And yeah.
Awesome. Mike, thank you so much for your time and for coming to share your knowledge with us and help us be better communicators, hopefully, and help us educate our patients better. So thank you so much for your work and for your time here with us today.
Absolute pleasure. Thanks for having me, Mariana.